coming up on the program, when the President of the United States gets a physical, it's not just personal, it's national news. But what do these high-profile exams actually measure? And should we expect more transparency, or for that matter, more from our own checkups? On this 4th of July weekend, we take a closer look at the history, politics, and science behind presidential physicals from a former White House physician and what they might teach us about our own health.
Support for What's Health Got to Do with It is provided in part by the American Brain Foundation. Invests in research across the spectrum of the brain, knowing all brain diseases, disorders, and injuries are connected. There can be no cures without research. Learn how you can make a difference today at AmericanBrainFoundation.org. Rethreaded knows human trafficking destroys lives, but they also know it's not the end of the story. Rethreaded believes in the potential and power of all survivors to reclaim their lives. Visit rethreaded.com to learn more. And Elevate Med. Through mentorship, leadership development, financial literacy, a robust peer network, and tuition-based scholarship support, Elevate Med is dedicated to the next generation of diverse physician leaders as a tangible step towards the eradication of health disparities. More at elevatemed.org.
From the moment we're born to our last breath, every American embarks on a journey through the intricate maze of the healthcare system. These are their stories, one life at a time. Today, we meet a former U.S. president. He was known for his optimism and cowboy charm. But during a routine physical, doctors discovered a growth in his colon, news that was initially kept quiet from the public. He underwent surgery, and he transferred power temporarily, setting a historic precedent. What was the diagnosis? And which American president made a quiet but critical health decision that shaped future transparency? Hi, I'm Dr. Joe Servin, a practicing neurologist at Mayo Clinic, professor of healthcare administration and policy at Arizona State University. This is What's Health Got to Do with It, which looks at where and how healthcare intersects with your life, helping you get the medical answers you want. Now let's turn our attention back to the U.S. president. That was Ronald Reagan. The diagnosis was colon cancer, specifically a malignant polyp that was discovered during a routine colonoscopy in 1985. Now, Ronald Reagan's colon cancer diagnosis and temporary transfer of power marked a turning point in presidential medical transparency. But decades later, how much has really changed? Joining us now is Dr. Jeffrey Kuhlman. He is a former White House physician, and he's going to walk us through what a presidential physical really entails and what lessons we can all take from the commander-in-chief's checkup. He joins us now from Orlando. Dr. Kuhlman, welcome back to our program.
Good to be here, Dr. Joe.
It's good to have you here. Let's start with history. I just talked about President Reagan. I remembered when this occurred. He had colon cancer and temporarily transferred power. Can you talk about how did that moment change the expectations around medical transparency for presidential physicals?
So let me just correct the record just a little bit and put a context.
Please.
So President Reagan was inaugurated in 1981.
Mm-hmm.
2 months later, there was an assassination attempt.
Yep.
Hinckley Hilton, he was taken to GW, George Washington. They saved his life with surgery. They did not invoke the 25th Amendment at that time. His physician at the time was a neurosurgeon, Dr. Daniel Rouget, who didn't have any equipment and was left on the sidewalk at the scene.
Oh, wow.
Then in January of 1985, President Reagan started his second term. Dr. Rouget had left, and they brought in a family friend, Dr. T. Burton Smith. Dr. Smith was a elderly urologist who was a family friend, and he served the position to the president. Fast forward a few months to July of 1985, President Reagan, as a 70-something-year-old, underwent a colonoscopy. Dr. Smith said, we don't need to do the 25th Amendment, and he compared the sedation to.
Dr. Coleman, let me ask you this quick question, just for our listeners who may not know. Remind everyone what the 25th Amendment says.
Sure. The 25th Amendment has four different sections, and the first section has to do with how you have a new president if there's an opening. The second section is vice president if there's an opening. This third section is if a president temporarily, voluntarily turns over their powers to an acting president. And the fourth section has to do with involuntary transfer of power. In U.S. history, think Nixon, think Gerald Ford for sections 1 and 2. So with 40 years ago, during the month of July of 1985, President Reagan had a colonoscopy, and during that colonoscopy, they found a big malignant polyp tumor in his ascending colon. They scheduled him shortly thereafter for a right hemicolectomy. They took out that part of the colon. Dr. Rosenberg was the chief of staff at National Cancer Institute, which is across the street from the National Naval Medical Center in Bethesda. So the Navy surgeons and staff did the procedure. Many people assume that President Reagan transferred power, but if you actually read history from people that were there, Dr. Smith did not advise properly, and most people say it was an ineffective use of the 25th Amendment. In fact, President Reagan submitted a letter to Congress, and he said, I understand the 25th Amendment, Section 3, but my Attorney General, my in-house counsel, think that did not believe this applied. So they did not invoke it, and that set us up for later. Dr. Smith was gone by the end of the year. A general surgeon from the Army, Dr. John Hutton, took over as physician to the president, and years later was one of his pallbearers. So Dr. Hutton took over. Bush 41 and Clinton both had medical procedures, but they did not need the 25th Amendment because they weren't put under general anesthesia. So most historians agree that the first proper use of it, the invocation of the 25th Amendment, Section 3, was June of 2002 for President George W. Bush colonoscopy that we did at Camp David. And I actually was the one that briefed him on that on Air Force One when we were flying back from a G8 summit. And all of that's in Chapter 11 of my book, Transforming Presidential Healthcare.
I love this, and I love the correction of history. I'm fascinated that, just to kind of follow up on that at the assassination and attempt of Reagan, that this was not invoked. I mean, that was like even way more serious than a routine colonoscopy, if you will.
Correct. There was lots of chaos and a lot of like who was even in charge and notification of the vice president. We learned a lot from that incident.
We are on our 4th of July weekend. When we think about patriotism, leadership, in fact, this is why one of the reasons we're talking about this topic on the show today. So what does it mean for a president's health to be considered a matter of national security? How would you frame that for our listeners? Why should we be caring?
The president has many unofficial roles, but the president of the United States has 3 formal official roles. They are the head of state, they are the chief executive of the executive branch, and they are also the commander-in-chief of the United States military. So arguably the most powerful military force in the world. The fitness of their mind, the fitness of their body comes into play as the role of commander-in-chief.
So walk us through, Dr. Coleman, you did these for many a president. Walk us through a typical presidential physical. How is it different, or is it? And I just kind of start us off from that perspective.
So the content is similar to what you and I and an American would get on their periodic assessment of their of their body. Eyes, ears, nose, and throat, chest, heart function, lung function, digestive function, extremities, orthopedics, skin, neurologic exam. But what's different is it's a scheduled time for the president and the doctor to address their specific health concerns and to do it in a private, secure environment. So it's usually done at Walter Reed Hospital, National Military Medical Center. It's done in the medical evaluation treatment unit. And that's where the specialists actually come to the president, and everything is done in a scheduled way to, get days worth of exams done in an hour or two. It revolves around the president, not around the healthcare system.
Understood. There's been so much talk because it's in public health now. We all worry about cognitive health, particularly for older folks. And our current president, our former previous president, even Ronald Reagan when he was president, these were older men. And I'm wondering if has that physical changed? Is cognitive testing even a part of this, or is this something that has yet to be adapted? Do we know if that's done now?
So in the Constitution, there's no requirement. There's not really any precedent. Having said that, the one physical impairment that we cannot accommodate for is critical decision making. So I am actually on the record. I was invited by the New York Times to write an editorial, which was published July 21, 2024. That's the same day that President Biden actually dropped out of the race a few hours later. Probably coincidence. But in it, I said, neurocognitive test should be standard for candidates, for presidents, for senior national leaders like Congress, the Supreme Court. I would make it past the age of 70. Obviously, it's up for discussion. We don't have a social will to do that. If we look at normal aging, cognitive decline, we know that past the age of 60, there's memory, reasoning, speed that all rapidly decrease, and vocabulary tends to actually stay intact. So if we look at an individual like President Trump turned 79 on June 14 a couple weeks ago, and compared to 59 years old, it's just a fact of nature that his memory, reasoning, and speed aren't the same as they were at age 59, and that is part of normal aging.
Got it. To all of our listeners out there, you're listening to What's Health Got to Do with It on WJCT News 89.9. I'm Dr. Joe Servin, and if you're just joining us, we're in conversation with former White House physician Dr. Jeffrey Kuhlman. And we're talking presidential physicals on this 4th of July weekend, and we want to hear from you. Tag us on social media at jservin. Dr. Kuhlman, when I've noticed in recent news, previous news, when presidential physicals are completed, like they were not too long ago for this year, they seem to sometimes seem more ceremonial than clinical. In your experience, is there a part of this that's for show, or is this truly a physical? Because a lot of times, everyone else, they don't announce when they're getting their yearly physical. I don't tell my colleagues that I'm doing that. So I wonder if you could address that particular issue.
Sure. The first thing would be who actually decides what goes into the physical. And so that's where the physician to the president sits down with the patient, which is the president, and says, here are the issues that I think we need to address in you. And they agree upon, a patient has to consent for the different testing and things that go on. And then who decides what gets released is actually ultimately the president, but hopefully they would follow the advice of the physician to the president and the senior advisors. What actually happens most of the time is they address health. And the definition of health, unfortunately, is absence of disease. So we focus on the absence of disease in those different organ systems. My opinion is the physical that's released to the public, to the media, that written report should be factual. It should be factual. It should be non-hyperbole. And if you march a doctor up in front of the White House press room, that tends to be more for show, and in my opinion, that's not helpful to reality. That may be more for political reasons, but that is not helpful to the patient or to the public.
Let me ask a question that towards a listener that's trying to kind of glean. They want to get, let's say, the same care that the president gets, to the degree that one can, given the difference in roles. What do presidential health disclosures get right, and what do they miss that maybe we should be thinking about in our own healthcare? What do you take away from your experience of having cared for these folks that we should be kind of looking for ourselves?
So the regular physicals that are out do tend to focus on absence of a disease. So that baseline is important, that information. It should go beyond that for an individual, and it should go into fitness. And an example of fitness would be aerobic conditioning. What's your VO2 max? What's your body fat percent? What's your gait analysis? And compare you to others that are in your age and sex category. And we actually did that with President Bush 43. He would run 3 miles in 18 and a half minutes, was kind of the best that he did during his first 4 years in office, which puts him in the top 2% of cardiovascular fitness.
Wow.
For a 57-year-old male, using the the Ken Cooper tables. The other thing is then he shifted into mountain biking, and he would go kind of 18 miles in an hour 10. So we should focus on aerobic and anaerobic conditioning. And then also with President Obama, we put him through a fitness assessment where many males especially, they do great in the gym with weights, or they may do great with aerobic conditioning, but they don't have the flexibility. So think of yoga, Pilates, and often those help. So I would focus much more on fitness, in addition to making sure that you have the absence of those chronic diseases.
As a former White House doctor, how I know you said that whatever is disclosed is up to the president, and I know we've talked about this when you joined us last time, but I'll ask it here because it seems to come up often. How do you balance, the president, the person's right to privacy, with the public's right to know?
Well, I think the public right to know is debatable. President Obama and I, when we talked about the physicals, he always told me never lie to the American people. I've learned eventually they'll find out the truth. So I tried to never lie to the American people. With that, the important things like, do they have heart disease? Do they have cancer? Are they up to date on their medical conditions? Are their chronic diseases managed appropriately? Blood pressure, cholesterol, glucose, those type of things.
Mm-hmm.
If there's certain things like, did they have hemorrhoids? Did they have skin tags? Is is a knee not working as well as it should. Some of that we just would choose not to include everything ad nauseum in detail, but if it's important to the American people, saying, is this individual fit to serve in this capacity and for their foreseeable future of their term, that's important information. And all of us are human, and if somebody has a bout of gastroenteritis, that may not need to be documented for eternity.
Dr. Kuhlman, in our final minutes, right now we are in the throes of a 4th of July holiday. And I'm wondering, under that theme of the holiday, celebrating independence, how can we take more personal responsibility for our health, especially when the system isn't very always transparent or accessible, similar to what you describe in many ways on the presidential health? What should we be taking on for our personal responsibility for our health from what you've learned from taking care of, kind of like Lily, one of the most important people on the planet?
So I would share health lessons from 4 of the presidents that I was privileged to take care of. This is outlined in a couple chapters in the book, Transforming Presidential Healthcare. With President Clinton, I've learned progress to a more plant-based diet.
Okay.
President Bush 43, lead a physically active life.
Okay.
From President Obama, temperance in your personal habits. This is a man that was a lifelong smoker.
Yes.
That in his first year of being president, he kicked the habit. And I think that is, if he can do it, president, and sustain that for his time in office, all of us should be temperate in our personal habits of and then from Bush 41, I took care of him as a former president a few times. I learned gratitude and positive outlook in life. There was no one I've met in my life that was more just a genuinely nice person and genuinely interested in others. And I think those 4 things together are the essence of whole person care.
Dr. Kuhlman, you have given us such a great message for this holiday weekend. I love the lessons from each of these presidents that you've had the honor to care for. I just want to thank you so much for the work you've done and for joining us today. I know you're very busy, and for sharing your insights and wisdom today.
Well, I'll say the same thing that I would always write in every president's birthday card. Happy birthday. I hope you have another.
I love it. That's terrific. We've been talking to Dr. Jeffrey Kuhlman. He's former White House physician. He's been talking to us about the presidential physicals and what we can learn from those physicals for our own personal health. Up next, after your weekly health headlines, we focus on the difference between emergency care versus going to an urgent care. And we'll be right back. Hey, it's Dr. Joe Servin. I have a new show called This Week in Health, and it's part of WJCT News Now. Local news you can listen to anytime, anywhere. When you sign up, you'll unlock 4 local podcasts delivered straight to your podcast app. I break down the week's biggest health headlines and what they mean for you. Start a free 30-day trial at wjct.org/newsnow. And if you like it, become a monthly donor to support WJCT Public Media.
Hi, I'm Stacey Bennett, producer of What's Health Got to Do with It, and these are your weekly health headlines. In a controversial first move, the CDC's newly restructured vaccine advisory panel, appointed by Health Secretary Robert F. Kennedy Jr., voted to discourage flu shots containing thimerosal, a mercury-based preservative long considered safe. The panel also announced their plan to re-review all pediatric vaccines over the combined effect of shots on children, raising questions about future changes to early life immunizations like hepatitis B and measles. According to a new CDC report, excessive drinking was linked to a 52% spike in high blood pressure deaths during the pandemic. From 2020 to 2021, an estimated 21,000 Americans died from alcohol-related hypertension. Over 60% of those deaths were in women. Just under 180,000 Americans die annually from excessive alcohol consumption, a preventable cause of death. Squeezing limes or lemons outdoors might lead to more than a refreshing drink. It can cause a phenomenon called phytophotodermatitis or margarita burn. This chemical reaction occurs when citrus juice on your skin reacts with sunlight. This rash is a common condition and can cause painful blisters, itching, and long-lasting dark patches. Dermatologists claim that the skin irritation can take up to 8 weeks to fade. The fix? Wash your hands with soap and water right after handling citrus in the sun. And for some good news, Nestle announced it will eliminate artificial colors from all its U.S. foods and beverages by summer of 2026. The move follows similar pledges by Kraft, Heinz, and General Mills as growing public pressure and new state and federal laws target synthetic additives, especially in school meals. Federal regulators are also cracking down. The FDA has banned Red 3 from the U.S. food supply, and Health Secretary Robert F. Kennedy Jr. says synthetic dyes should be phased out by the end of 2026. Nestle made a similar promise in 2015 but didn't fully follow through. This time, the company says 90% of its U.S. products are already dye-free, and it's renewing efforts to meet evolving consumer preferences and federal regulations. And those are your weekly health headlines.
Welcome back to What's Health Got to Do with It. I'm Dr. Joe Servin, and if you aren't Commander-in-Chief, how do you know where to go when every minute counts? Let's meet Marissa. On the 4th of July, Marissa, a 38-year-old teacher, twists her ankle stepping off of a curb while watching fireworks. Her ankle swells quickly, and she can't put weight on it. She feels dizzy, but has no chest pain or trouble breathing. It's after 7 p.m., clinics are closed. It's a holiday weekend. Where should she go? Urgent care or the ER? Marissa likely has a severe ankle sprain or possible fracture, painful but not life-threatening. If she can find an open urgent care, that's the right move, but on a holiday weekend, many of us wonder, when is it okay to wait? And when do you go straight to the ER? To help sort out this age-old question on a holiday weekend, we're joined now by two emergency care experts from HCA Florida. First, we have Dr. Shilpa Amin in studio. She's medical director of the emergency department at HCA Florida Memorial Hospital. Dr. Amin, welcome, and it's so good to have you here.
Thank you. I'm really excited to chat with you today.
And online, we have Dr. Denny Rhodes. He is Regional Market Medical Director of HCA Urgent Care, Care Now, and MD Now. Dr. Rhodes, it's good to have you on our program.
Oh, I'm just so excited as well, and thank you so much for having me.
We are excited to have you both. So we're going to get right into the meat of this. This is a question that I even talk over with my wife, my family members, when this comes up a lot. So, Dr. Amin, I'm going to start with you. How do you define the role of, in this case, the emergency department when someone needs help fast?
Sure. So it sounds like Marissa, she stepped off the curb and had initial swelling and some dizziness. So I would be concerned about a couple of things going on there. I would say she should come to the ER for evaluation. Sounds like she has a fracture. We have a team of physicians that can take care of her. If there's a deformity, if there's a dislocation, we have orthopedic surgeons there, ER doctors, we can get x-rays, CAT scans, and also we can deal with the dizziness as well.
Dr. Rhodes, I'm going to turn to you. Talk to us about where the urgent care mission fits in to a case like Marissa's.
We are very, very able to take care of Marissa as well. It all depends on, her availability, how close is she to the ED, how busy the emergency department is. In this case, most of our urgent cares are open from 8 a.m. to 8 p.m. You gave the time of 7 p.m. So we would be available. The urgent cares in HCA urgent care, which include CareNail outside of Florida and MDNail in Florida, we have X-ray availability. Our providers are trained to look at the X-ray, interpret if there's a fracture or not, and if there is a fracture, we can splint it until the patient can get to an orthopedic doctor the following day or 2 days or 3 days, however long it takes to get them into an orthopedic physician. But as far as the follow up from there, then yes, we're able to take care of whatever they have going on with the fracture, the swelling, any pain that they're in having or experiencing.
Got it. So, Dr. Amin, I'm going to kind of turn to you. Speaking as someone who is a director of an emergency room, if you will, what are those, just for our listeners, what are those top red flag symptoms that says, don't wait, go to ER directly, don't look for but just go to the ER? Can you summarize a few of those?
Definitely. That's a great question. So if somebody's having chest pain that's radiating to their jaw or to their arm or to their back and they're sweating and they're at risk of having a heart attack, definitely come to the emergency department. If they have sudden onset of weakness or they're fearful that they're having a stroke, they should definitely come to the emergency department. If they're having difficulty breathing, speaking 1 to 2 word sentences, can't catch their breath, not just a simple asthma attack, they should come right away to the emergency department. If they fell and have a deformity of their ankle, maybe, broke the skin, the bone is sticking out, that's something you need to come to the emergency room for. A laceration, if you can't control the bleeding and it's very big, it's complicated, definitely come to the emergency department. If somebody is, fearful that they have sepsis, so if they have a high fever, everybody has the watches now that tell them how fast their heart is beating. Yeah. So if it's something that is very high, they should come to the ER right away.
Got it. That's actually great summary of those elements. Dr. Rhodes, I'm going to kind of bend the question in a slightly different way. What are the most common problems that land in the ER unnecessarily, perhaps, and could be better handled in an urgent care?
Wow, that's a great question as well. You got a lot of great questions.
I appreciate that.
I love this. I love this. But and Dr. Amin and I, believe it or not, we just talked about this a couple of weeks ago when I was we were together in a meeting. But there's a lot of things that people will show up with. They have a cough. They've got a little bit of a fever. Our bread and butter is upper respiratory infections. That's one of the most common things that we see going to the emergency room that really they don't need to go. An upper respiratory infection is anything your nose is congested. Oh, you have an earache. You might have a sore throat. You may have a cough. And excuse me, I gave you one there just to show you. Dry cough that from talking too much with Dr. Joe. But you're not really super sick, but it's just hanging on, it's clinging on. I'm concerned. I've got little ones at home, that type of thing. And I worked the emergency room too as well many moons ago. And yeah, we would take care of anybody who showed up. We're there to take care of anybody. But the cold that comes in at 2 a.m. in the morning when you're dealing with fractures and lacerations, it just bogs down the emergency room to where they can't take care of the really, really sick people. And where urgent care falls in is like the minor lacerations. Dr. Amin mentioned that the really deep, right, massive hard to stop the bleeding, absolutely. We tend to send those to the emergency room anyway, but of course we can wrap them up and stop the bleeding. But minor lacerations, insect bites, dog bites, or animal bites, we can assess anything, and our providers are able to assess anything. But a lot of times the patients get frustrated whenever they come into the urgent care, and we have to say, oh my gosh, you've got to go to the emergency department or emergency room. And she gave you a great summary of those things. But if you're not sure, I always tell folks, don't not go to one or the other. If you're not sure, you're more than welcome to pop into the urgent care. We can assess the patient. And a good 80% of the time, things that go to the emergency room don't get admitted, but there are some things that we just don't do in the urgent care. So like IV fluids, we don't resuscitate people if they're, they've been out in the sun too long and they're fainting. Again, anybody who's fainting or dizzy, you don't know, am I having a stroke or am I having sunstroke or am I just dehydrated? Yeah. Those are the things that we can't adequately assess in the urgent care. Do you have abdominal pain? Well, we can't do a white count to see is your abdominal pain and appendix. So those are the things that we would certainly assess people, but then send them on to the emergency department.
Since we are talking during a holiday weekend, I 4th of July, the perfect example. What kinds of injuries or issues do you see more of, and where should those patients typically go? And I'm going to start with you, Dr. Amin. Holiday weekend, a summer holiday weekend. What's the typical things that you go, and where should they go?
So we see a lot of burn injuries. So if a patient has a burn from using the barbecue, maybe they had a couple too many drinks and they're flipping burgers. If the burn is severe, if it goes over a joint, if it's causing a lot of pain, come to the emergency room. If it's just a very small burn, an urgent care can handle that. Sometimes these burns have to go to specialized burn centers, so it's always good to have an ER doctor, lay their eyes on the injury, and then they can treat them as needed. Other things that we see a lot on the 4th of July are hand injuries from people misusing firework. It's a really big holiday for people to lose hands, fingers, things like that.
Wow.
So that's something very common. And, the ER is staffed 24/7 with emergency medicine board certified doctors. There's trauma surgeons at Memorial, hand surgeons on staff that can deal with all of these emergencies.
Dr. Rhodes, I'm going to ask you the flip side of the question I asked Dr. Amin, which is, with urgent care offering so many things, x-rays, labs, some even offer IV treatments. Can you talk a little bit about where do you draw the line before sending someone to the emergency room?
Yeah, the line is kind of blurry. And it tends to shift depending on the patient's age and their other medical conditions. What I usually recommend to people who are calling in and asking us in the urgent care, should I go to the emergency department? Our answer always is, if you feel that it's a life-threatening situation, that you're bleeding, severely, or you're having the chest pain or severe abdominal pain, you may be better off just going straight to the emergency department. Anything else, or if the patient themselves aren't sure, they're more than welcome to come in and we will assess them. We'll see anybody who walks through our doors and assess them and then determine, do you need to go to the emergency department or not? So where the line is, if you have a young person, with fever, like Dr. Amin said, a fever can mean severe infection. We can at least check into what's causing the fever. If we can find the urgent problem and fix it, great. If it's something a lot more complicated, like we can't find the source of the fever, it's what we call fever of unknown origin, then absolutely you need to go to the emergency department to get lab work done. What we offer in our office is, flu, COVID testing. We can check your urine. We can check to see if you're pregnant. We can check to see if you have mono. But if you're worried about a more severe infection, like, I may have sepsis or I might have a severe kidney infection, of course, we can check for that and treat for that if you're young and healthy and not having any problem. If you're older and you have what we call comorbidities, you have diabetes, you have heart failure, you have some kidney disease, and then it starts to get a lot more complicated. Should I be in the hospital or not? And that's where, of course, we can evaluate the person first. But if you're an older person with lots of comorbidities and you're pretty darn sick, you may be better off going to the emergency department first.
Got it. And to all of our listeners out there, you're listening to What's Health Got to Do with It on WJCT News 89.9. I'm Dr. Joe Servin, and if you're just joining us, we are talking about urgent care versus emergency room care. And we want to hear from you. Tag us on social media at jservin. Dr. Amin, when time and speed really matters in care, I'm just as a general sense, how does the ER prepare for those, in essence, life or death minutes, if you will?
Sure.
A little different from the distinction we're making, but just talk to us a little bit about that part.
Sure. So we have different activations. If there's a trauma that's coming in, EMS will let us know that there's a level 1 trauma coming in 15 minutes. That gets alerted out to the entire hospital. So the ER doctors and the team can prepare. The trauma surgeons come down, anesthesiologists, an entire team is there waiting to recept that patient from EMS. So we are ready for that patient before they even arrive. We start preparing. If there's a patient that is having a heart attack, we'll call a code STEMI overhead. We'll activate the cath lab team, we'll call the cardiologist, and we'll get the patient over to the cath lab immediately. So for these life-threatening emergencies, we have teams that are prepared that do this day in and day out so that not a minute is wasted. Same thing for stroke. We have an extremely expedited stroke protocol that we use. If a patient comes in by EMS, we'll alert the team before they get there. If they walk in, they'll come over to our rapid assessment bay where they'll see a teleneurologist or a neurologist. The pharmacist is there. They go right over to CAT scan. CAT scan is attached to our emergency department, and they'll get evaluated as they're getting onto the CAT scan table. They get the CAT scan within minutes of walking into the ER. So we're experts in life-saving treatments, emergencies. So we have teams that are prepared to take care of our patients.
I love it. So I'm going to now segue a little bit, and we're going to have a little fun on a serious topic. We're going to play urgent care versus ER. I'm going to kind of point a just general symptom to each of you, and you tell me which one and a sentence why. That's it. No long answers.
And we're assuming that it's during the day because, the ER is open 24/7, 365.
I'm gonna let you choose the assessor, but we're gonna play this game and see how this goes. I'm gonna start with you, Dr. Rhodes. And again, real easy: urgent care or ER, and a sentence why. So here we go. Are you guys ready?
We're ready.
Okay.
I'm ready.
All right, Dr. Rhodes, chest pain.
ED.
Dr. Amin, sprained ankle.
Urgent care.
Dr. Rhodes, high fever.
I'd say urgent care.
Dr. Amin, facial droop.
Definitely the emergency room.
Dr. Rhodes, suspected food poisoning.
I would say urgent care.
Okay. Dr. Amin, barbecue burn.
Barbecue burn, I would definitely say the ER.
Okay. Dr. Rhodes, shortness of breath.
I would say urgent care.
I would say ER.
Okay.
Shortness of breath.
We got a split vote on
Yes.
that. Okay. We'll put
Sure.
that.
That's okay.
You want to add a sentence?
I would. If somebody is coming in with shortness of breath, they may need to be put on, they may need Duoneb medications. They may need an x-ray to see if they're, having a pneumonia. They may need, if it's very severe, to be put on BiPAP. So it really just depends on the shortness of breath.
Got it. Okay.
Right. And the age and the comorbidities. If you have a COPD patient who's short of breath, yes, I would say ED. You have a 28-year-old who just got done running a marathon, or no, I wouldn't say marathon. I take that back. They were rushing to chase down a child that was going into the street, and they're
Sure.
short of breath because they're out of shape, and there's different. That's when it's that gray line that moves depending on what other problems are going on.
Got it. Okay. I'm going to continue on. We only have a few more. Dr. Mean, a dog bite.
A dog bite can be handled in the urgent care.
Okay. Dr. Rhodes, a migraine headache.
That can be managed in the urgent care.
Okay.
I would say, we see a lot of, so that's in our top 10 most commonly seen diagnoses in the emergency room. And depending on the severity of the migraine headache, if they're taking oral medications and it's not working, oftentimes we will have to give IV medications, some fluids, multiple reassessments. So, depending on the severity of the migraine headache, I would say that the ER may need to handle it.
And I would agree. But where I would make the caveat is, someone who has migraines, they know they have migraines, they ran out of medication. Oh, I didn't get in to see my doctor. I don't have my migraine medicine, so therefore I have the migraine. But I agree with Dr. Amin. Somebody who's on migraine medicine, they're taking it, and it's not working this time. Something else is going on. So that's ED.
All right, Dr. Amin, I got the last one for you. Severe abdominal pain.
Emergency room. That patient's going to need a CAT scan, blood work. There's a lot of different organs that live in the abdomen. So we need to figure out where that pain is originating from. So they need to come to the ER.
I agree completely. Abdominal pain coming into the urgent care, it's just, you pull out your crystal ball and you say, okay, now if it's a urinary tract infection and all the symptoms go along with a bladder infection, okay, that's an easy out. But if it's anything other than the bladder, it's upper abdominal, it's off to the side, it's radiating to the back. That can be anything from pancreatitis to a peptic ulcer. You could have an obstruction. You could have diverticulitis. So I agree. ED is the main course if you're having abdominal pain.
Okay. So the nice thing is I don't have to declare a winner, because a winner is anyone listening and knows what to do now in these different things. So that's so I appreciate that. In our final moments, I'm going to start with you, Dr. Rhodes, and I'll go to Dr. Amin. Dr. Rhodes, I want to give you this moment to answer this question. What's your golden rule for our listeners out there trying to decide where to go when something happens unexpectedly?
My golden rule is, as we mentioned before, if you're concerned enough that I might lose, a limb, I might lose my life, or the person that I'm looking at, is not responding correctly, or I'm just concerned that they could die, go to the emergency department. That's always my golden rule. Are you afraid enough looking at that person that they could have serious harm to them? Go to the emergency department. If something that's run of the mill, but you don't want to wait to see your primary care doctor in 5 days when you get an appointment, absolutely come to the urgent care.
Dr. Amin, I'm going to give you this final word for this a holiday weekend for the golden rule, as the same question that I gave Dr. Rhodes.
Sure. So I would agree with Dr. Rhodes. If it's life, limb threatening, just come to the ER. We can take care of minor things and major things. And if you're not quite sure where to go, just come to the ER, because we can take care of little problems and big problems. Sometimes people are like, oh, I wasn't sure. I went to the urgent care, then they have to get transferred. So if it's, if you're in the middle of nowhere, just try to find an ER and we will take care of you.
I want to thank you both for the work that you do, for being so good and playing our game with us and just giving us these great insights and wisdom. Thank you so much, Dr. Amin.
Thank you for having me today. I had a great time.
It's great. And Dr. Rhodes, thank you so much as well.
Oh, no, I just appreciate the opportunity. This is a great discussion, and I'm happy that you gave us a forum to talk about it.
It's been wonderful to talk to both of you. We've been chatting with Dr. Shilpa Amin. She is medical director for the emergency department at HCA Florida Memorial Hospital. And Dr. Denny Rhodes. He is the regional market medical director for HCA Urgent Care, Care Now, and MD Now. Well, that's our program for today. We hope you've enjoyed our show. If you missed anything, you can listen to the full episode at wjct.org and on your favorite podcast app. Thanks to all of our guests. Our executive producer is David Luckin. Stacey Bennett is our producer. Brady Corum is our director. Caden Collins and Caroline Kahn are our researchers. If you have any questions about this or any topic, let us know by calling us at 904-358-6362. Email us at health@wjct.org or tag me on social media at jservant. I'm Dr. Joe Servant, and you're listening to What's Health Got to Do With It on WJCT News 89.9 Jacksonville. Thank you for listening. and stay in touch.
Support for What's Health Got to Do with It is provided in part by the American Brain Foundation invests in research across the spectrum of the brain, knowing all brain diseases, disorders, and injuries are connected. There can be no cures without research. Learn how you can make a difference today at americanbrainfoundation.org.
Rethreaded needs you to make a difference in the lives of human trafficking survivors. Learn more about supportive services and an array of survivor-made products at rethreaded.com.
And by Neurelis, a leading neuroscience company focused on the development and commercialization of therapeutics for the treatment of epilepsy and other neurologic disorders. The company's unique drug portfolios strive to address unmet needs in patient care. Learn more at Neurelis.com.